upper extremity. It becomes a bit more organized, and we'll get to that. I want to make sure your mind's clear what nerves we've covered. So we started out with facial nerve, and that innervates what group of muscles? Muscles of facial expression. Right, the next one we covered was trigeminal. And that was the third branch of the trigeminal nerve. Mastication. The next group of muscles that we did were the ones that formed the floor of the mouth. Actually, that we did another nerve. Aqualogical nerve, and that was the tongue. Okay, then we did the muscles of the floor of the mouth, and that had a variety of different nerves that I said you didn't have to worry about. But I did ask you to learn the nerve that innervates the one single infrahyoid muscle we covered, which was sternohyoid. Anybody remember the name of that nerve? It innervates all the infrahyoid muscles, all the hyoid ones that are below the hyoid bone. It has the loop that lies on the lateral aspect. And it's the cervicalis. So it does infrahyoid, but the only infrahyoid that you have on your list is sternohyoid muscle. Then we did the sternocleidomastoid muscle. Anybody remember the nerve? It's another cranial nerve that innervates that one. Cranial nerve 11. How do you remember that one? Accessory nerve. And that's a sternocleidomastoid. And then one that we talked about as a muscle that moves the scapula. It's antagonistic to itself. Anybody remember what that one is? Elevates and depresses the scapula. Does this.
The traps.
For its shape, trapezius. And then I was kind of quiet on innervation for a while. We had just a general term of nerves that innervated sphenius capitis and semispinalis capitis, the three sets of erector spinae muscle, quadratus femorum. Anybody remember what we called that group of nerves? We didn't name any one particular nerve. The dorsal rami. The dorsal rami are those branches of the spinal nerve that do deep muscles of the back. All along, just lateral to the aspect of the spinal column, the spinalis, involved in moving keeping erect the vertebrae. Okay, then we moved around to the front, and we did muscles of the chest. So we had intercostal nerves, and those innervate the three sets here. They're really easy. The facial, the hypoglossal, the intercostals innervate intercostals. So both the external and internal intercostal muscles are going to be innervated by the intercostal nerves. And what was the other respiratory nerve, muscle that we discussed? The phrenic nerve for what muscle? The diaphragm. And then we did the internal and external obliques and the rectus abdominis. Those are done by a continuation of the pattern of the intercostal nerves, but we're done with T12, and so we're looking at L1 and L2, and I don't think I actually wrote these on the board. They were in your lecture notes. Notice the ilio having to do with the attachment of these muscles anterior abdominal wall muscle. And then we started looking at muscles of the upper extremity that cross from the scapula to the into the arm. And while we talked about these muscles, I hadn't actually written their nerves up on the board. And there's only, you're not responsible for learning the nerves of all of them, but the nerves for two is the axillary nerve, and that innervates the deltoid, which we discussed on Wednesday, and teres minor. You don't need to worry about supraspinatus, infraspinatus, teres major. Now, that brings us then to the nerves within the compartment of the upper extremity. An axillary nerve is one of a group of what we know called terminal nerves or main nerves that come from, and again, we'll pick this concept up again with our nervous unit, but comes from a group of ventral rami, C5 through T1. This is for free, okay? We're just going to worry about the names of the nerves, but to give you a background for that, these come off of the spinal nerve, forming a brachial plexus. So the axillary nerve is one of those brachial plexus components that are formed from the interweaving of these spinal nerves. And the axillary nerve is primarily C5 spinal nerve, but it has some of C6 in it. Again, this is still for free, but I'm illustrating the interweaving that occurs. As the ventral rami of those spinal nerves move into the upper arm, they end up forming several primary terminal branches that we're going to use as we talk about the innervation of the upper extremity. And the upper extremity is divided into anterior and posterior compartments. I went over that a little bit when we were looking at the muscles of the anterior and posterior arm in lab on Wednesday. And so innervation for these compartments comes from the brachial plexus. So remember, the arm is from shoulder to elbow. Okay. That's divided into the anterior arm. The muscles in the anterior arm are going to cross the shoulder joint and the elbow joint. One muscle crosses only the shoulder joint. One muscle crosses both joints. One muscle crosses only the elbow joint. All right, and we'll look at those today. But as such, would this group of muscles be doing flexion or extension? Flexion, adduction or abduction? Adduction. All right, because they're medial. They're coming medial. So these muscles, in general, function in adduction and flexion. And then in lab, we look at the posterior arm. These muscles, again, all of them will cross the elbow, and some will cross the shoulder joint. One will. As such, they function in extension because they're posterior. They're going to be pulling the arm in this direction. The nerve that innervates the anterior arm, the nerve that innervates the anterior arm, is known as the musculocutaneous nerve. It's motor to muscles of the anterior arm and then becomes sensory as you run your hand down the side, the lateral aspect of your forearm. The posterior arm is innervated by the radial nerve. We you have one nerve that innervates the back of the arm and the back of the forearm. That makes it easy. Radial nerve, that's all the posterior components. All right, we'll see a similar pattern of innervation when we get to the lower extremity. One nerve will innervate all the muscles in posterior thigh and posterior leg. So if you can remember that, then you're not having to learn a new innervation for every muscle one at a time. It's in that compartment, it's going to be innervated by that muscle. Okay. Anterior forearm. Is going to cross the elbow, cross the wrist. Most of them will cross the wrist. And some of them will even cross into the fingers, what we call NP joints. That's metacarpal and phalangeal. That's the knuckles. And IP joints, which are interphalangeal. Again, primary function, the anterior is going to be flexion. We do have some supination, pronation in there as well, but primary function is flexion. Posterior forearm, does the same thing. Crosses the elbow, crosses the wrist, crosses the finger joints. Primary function again is extension. So muscles of the posterior forearm are going to be doing this, they're going to be doing this, they're going to be straightening out the fingers. Well, we already know the nerve to the posterior forearm, radial nerve. And the primary nerve to the anterior forearm is called the median nerve. There are a couple of exceptions done by the ulnar nerve, but we'll talk about that when we get to it. So in your lecture notes, the online lecture notes is a table that kind of lays this out for you as well. So remember, I'm introducing this now, taking a little bit more time to talk about it, but these questions on your lecture exam, which is a week from today, sorry to bring you bad news. It means we get to move into the nervous system. So the questions on the nerves will be a matching type of questions, the last 66 to 72 on the last page or wherever it is in there, where I ask you to provide the nerve for the compartment or the nerve for that muscle, a combination of those. Okay. Any questions on that? Then we'll be going through it. So another way of looking at this is if you cut the musculocutaneous nerve, all right, would you still be able to flex your forearm? Notice flexing the elbow is one of the functions of some of our muscles in the anterior arm, but so is flexing the elbow part of our anterior forearm, which is a different nerve. So if we cut the musculocutaneous, we'll lose the strength of flexion of the elbow, but we'll still be able to do it. All right, we'll lose the agonist, but we'll still be able to do some of that function. All right, so let's go back, do a little bit of where we were at the end of lecture, and what we covered in lab. Again, we'll use the overhead slides. We've gone through these first few slides already at the end of lecture on Wednesday. talked about the deltoid. Remember that wraps around the shoulder? And because it's both an anterior and a posterior muscle, it's going to be able to do flexion as well as extension at the shoulder joint. And because it inserts on the deltoid tuberosity, it's going to be able to do abduction. But it cannot do adduction. So again, rather than memorizing what these muscles do, use those origins and insertions for the reason which I'm giving them to you, not just a fact to learn, but to help you understand how the muscle is doing its function. After we removed the deltoid, we looked at a series of muscles that I didn't really go into much, except in lab, where I said they were rotator cuff muscles. Their tendons are external to the ligaments of the shoulder joint. The ligaments are external to the synovial cavity. But these tendons, as they cross over from the scapula to the humerus, support and strengthen the joint capsule. So there are 4 muscles identified as rotator cuff muscles, and they're, don't get busy with that thing bouncing up and down, but it's the projector, not the screen. They form the word sits. So starting at the top, we have supraspinatus, and then we have infraspinatus. And then inferior to infraspinatus, we have teres minor. So these are the 3 posterior muscles that form the SIT component of sits. Infraspinatus and teres minor are also important in doing their function as lateral rotation. Remember, lateral or external rotation is taking the humerus and rotating it on its length. So it's turning as if, that's why I have my elbow flexed, so you're not thinking I'm doing this, supination and pronation. This would be external or lateral rotation, this would be internal or medial rotation. And so all 3 of these muscles insert on the greater tubercle. You just kind of slide down the scapula and function. The supraspinatus, however, doesn't function in lateral rotation. If you look at its angle, it's coming over the top of the scapula. So what is its function without looking in the lower left? Get your eyes away from that part of it. Abduction, exactly. Okay. So someone whose nerve to the supraspinatus has been damaged would drop their shoulder. That gives it the 30 degrees that the supraspinatus provides, and then they can use their deltoid. So if they need to brush their hair, they're not going to be able to take their deltoid and go like this. They need the supraspinatus to get that started. Supraspinatus is paralyzed. They can do it by doing that. And then the deltoid has the proper angle of action. All right, so we looked at those 3. And then in lab, we looked at the other component of the sits muscle, the one that comes from the front, and this is subscapularis. So its origin is the subscapular fossa. All right, notice it's attaching anteriorly here to the lesser tubercle. That's why I love these pictures from this Washington site, is because you can isolate that muscle and actually see where it's attaching. So is this going to do medial rotation or external rotation from that position? The process comes from the anterior scapula, crosses under the front here, abs onto the lesser tubercle. So when it pulls, it's going to pull the humerus medially. So if it's doing the opposite function as far as rotation is concerned, and you can see that here from this attachment. So those are the sits. Those are the rotator cuff tendons. Then if we go back to a posterior view, we have teres major. Even though teres major and teres minor share the same, teres means round, kind of cord-like, it inserts onto the anterior aspect of the humerus. So it also is going to do medial rotation. So teres minor, coming from a similar location, inserts onto the posterior lateral aspect, teres major onto the anterior medial aspect. So they have opposite functions. One comes around, if this is the humerus here, teres minor is going to do this and rotate externally. Teres major coming from inside is going to do that. So they are on opposite sides of the bone and have opposite functions. Those 2 muscles, if you recall, are split by which head of the triceps brachii? Long head, the only one to cross the shoulder joint. All right, we didn't discuss this in lab because it wasn't one that we were looking at with the upper limb model. The latissimus dorsi, you may know it from lab workouts, gym workouts as lats. It's a huge but thin muscle that kind of is the opposite pair of trapezius as far as its appearance. So trapezius is a trapezoid-shaped muscle and the superior aspect of the back. Turn that around, and then latissimus goes up in the opposite direction, but instead of inserting onto the scapula, it inserts onto the humerus. So it's not going to move the scapula at all. And it inserts onto the shaft of the humerus. Kind of on the inside. So it does medial rotation because it's coming up from the inside, but its major function, you're in the gym, you reach up and grab the bars above your head and pull down. What movement is that at the shoulder? Extension. So that's the major function of the latissimus dorsi, is extension. Okay? If the arms are out, it can pull in and it can do medial rotation, but its major function, think of reaching up and grabbing onto that bar and pulling down. So that's the latissimus dorsi. It's going to be superficial to the erector spinae. So that has to be dissected away to be able to see the erector spinae. All right, and then before we actually move into the muscles that lie along the humerus itself, we have pectoralis major. It has two heads off of the sternum, and then another head off of the clavicle, so much so that if you were dissecting this in the cadaver, it would seem like it was two separate muscles. But they come together and then kind of rotate into a twist and attach in a very similar position as the latissimus, but from the front. So they're going to do adduction and flexion because they're coming from the front. So they're in a similar position of attachment, but they're coming from the front. They're going to do flexion. They're going to actually come. These muscles don't do as much flexion. The flexion is primarily coming from these muscles here. You don't need to know innervation of any of these muscles, except for deltoid and teres minor, which is excellent. All right, so this begins the group of muscles that are in the anterior compartment of the arm that we covered in lab without actually doing lecture. Coracobrachialis, named for its 2 points of attachment, innervated by musculocutaneous nerve. So we have 3 muscles in the anterior arm. This muscle crosses only the shoulder joint. You can see it's too short. Its insertion is on the arm, hence brachialis. Origin is the coracoid process which shares that attachment with what other muscle? For this muscle, it's the insertion. What's the muscle that you do this to locate? Comes off the ribs, inserts onto the coracoid process. Pectoralis minor. Okay? So it shares that attachment with pectoralis minor, inserts onto the humerus, and therefore, again, as we wrote on the board, flexion, adduction is anterior to the shoulder joint. Let's skip into the deeper muscle here. Brachialis also has a word for arm in its name. Brachialis origin, it doesn't cross the shoulder joint. It crosses only the elbow joint. This is the agonist. Remember the prime mover, if you will, for flexion of the elbow. So is it going to insert on the radius or on the ulna? What are the 2 bones that form the elbow joint, the hinge joint of the elbow? Humerus and ulna. So because this is the prime mover for flexion, its insertion is on the ulna, not the radius. And it's on the coronoid process. So the biceps brachii will assist it, but this is the prime mover. It doesn't cross the shoulder joint, so it doesn't do any other function at the shoulder. It flexes the elbow. All right, back to the superficial muscle which covers it. And in lab, to see brachialis, you need to take off the biceps brachii. You can kind of see it on the side, but to fully see it, you need to take off the biceps brachii. Biceps brachii, biceps because it has 2 heads of origin. Again, notice we're using the coracoid process. So 3 muscles attached to the coracoid process. Coracobrachialis, pectoralis minor, and the short head of the biceps brachia. In lab, the long head, which crosses over, it goes through the interpedicular groove and crosses over the head to attach to that supraglenoid tubercle. It looks shorter because part of this tendon is covered by the joint capsule, or connective tissue and ligaments, but it actually has a longer position to travel. Its primary function is supination. So it's going to take the arm, forearm, and turn it palm up. So what bone are we moving when we do that? Radius. Any muscle, broad rule here, will help you save some moments of anxiousness. Any muscle that does supination or pronation has to, by definition, insert onto the radius. Because the ulna doesn't move when we do supination and pronation. We actually have a muscle called the supinator. It has to insert onto the radius. Because it crosses the shoulder joint, it's also going to do flexion and abduction, which I don't have on here, but it crosses the shoulder joint, so it's also going to do that. And because it crosses the elbow, it's also going to do flexion, but it's a synergistic muscle for flexion. It's not the prime mover. It's the prime mover for supination. And when you're in the gym and you're doing curls, all right, you can do the curls like this, or you can rotate and do the curls like this, and that helps to isolate out just the brachialis. All right, posterior compartment of the arm. The nerve, radial nerve. Anything posterior arm or forearm is going to be radial nerve. Function, anything posterior arm and forearm is going to be extension. Here we have 3 heads. One head crosses the shoulder joint, the long head. That's the only part of the posterior arm that does extension at the shoulder. All right, the primary mover for that is deltoid. Teres minor, infraspinatus can help. That's not their major function. But the primary mover is deltoid. This will also assist. All 3 heads, long head, lateral head, and the short little medial head, which is shown a little larger than it usually is, come together at a common tendon. Major function is extension of the elbow. So again, the bone is going to be the ulna. And this process of the ulna is the olecranon process. So that's the insertion. It's opposite, it's posterior to the coronoid process. So that's the insertion for the triceps brachia. And then in lab, we looked at a small little muscle on the opposite aspect of the triceps, which is the anconeus. It doesn't quite go to the olecranon process, but it's going to also help to extend the elbow. Doesn't do anything else. So we've covered those in lab, but not done the lecture part. And now let's move to the forearm. Forearm is elbow to wrist. And let me lay down some ground rules here that will help, except for one muscle that we look at. All the muscles in the anterior compartment are going to have their origin from the medial epicondyle. Okay, one of the deepest muscles that we look at does not. But everything else, that's a common origin. Anterior compartment. In fact, if you have short sleeves and you flex your wrist, you can feel these muscles right here on the medial side, the little finger side of your forearm, shortening and bulge, okay, as you flex your wrist. Then as you extend your wrist, this group of muscles coming from the lateral epicondyle, all right, share that common origin. And the two together make a kind of V-shaped groove in your elbow facet. So, common origin for everything on your list except for flexor digitorum profundus. The very bottom is going to be medial epicondyle. You can just put ditto points all the way down. Pronator pronator teres, by its name, is going to take the forearm and turn it this way. Right? So So it has to insert onto the radius. Now these muscles we're looking at are individual muscles. However, we have 3 layers of muscles in the anterior forearm, what we call superficial. And then through the tendons of the superficial, you can see a single muscle in the intermediate layer. And then that muscle needs to be removed to see the muscles in the deep layer. Okay. So again, the anterior forearm is probably the most complicated of all the areas of the muscle in the body to identify on the model because of those 3 layers. You keep that in mind, in fact, that you have those 3 layers. You keep in mind whether you're medial or lateral, whether you're radius or ulnar side. That will help you keep this straight. You just have to go through those steps each time you identify a muscle. So pronator teres is crossing from the medial epicondyle over to the radius. When we get to the lateral compartment, we'll have brachioradialis crossing over here, and that creates that V. So I'll point that out in lab. It helps you get started with a common a place to begin with each of these comparisons. The next muscle. So pronator teres is going to be going here. The next muscle in line is still lateral. Flexor carpi radialis. Carpi refers to the wrist bones, the carpal bones. So flexor carpi radialis has to cross these, hence it's going to flex the wrist. Pronator teres did not cross the wrist, so it can't do anything at the wrist. Certainly it can't do anything at the fingers. Okay. So flexor carpi radialis is going to cross the wrist. So not only is it going to flex the elbow, but it's going to flex the wrist. When it crosses the wrist, it attaches to the lateral aspect. So not to the radius, even though it has radialis in its name, but on the radial side of the hand, to the 2nd and 3rd metacarpal. Right here. So as that, it's crossing 3 sets of joints. Okay, it's crossing, well, actually 2 sets. It's crossing the elbow. It's going to do flexion. It's crossing the wrist. So it's going to flex the wrist. And because it's crossing the wrist laterally, it's going to do this movement. So this can be described as abduction of the wrist or radial deviation. Again, if you visualize that, feel it contracting as you move it, that will help. Now as we move medially, the next muscle in line is called the palmaris longus. So we have pronator teres, flexor carpi radialis, and then coming down the midline of the forearm, palmaris longus. Again, notice medial epicondyle. This one crosses the elbow joint and crosses the wrist joint, but it goes into the middle. It doesn't even go to a bone. It goes to a broad band of connective tissue. Remember the term aponeurosis? It's just a broad band of thick connective tissue in the palm of your hand. So it inserts on that. This is a very short muscle with a very long tendon. It actually has a homologous structure in your leg, not one that we look at, but it's a very, the muscle in the leg comes off from the femur is only about 2.5 inches long, and the rest of it is a tendon. It ends up being used for grafts. So if someone needs a graft for a knee anterior cruciate replacement or lateral replacement, they'll often use this tendon because you probably don't even miss that muscle. And then the most medial muscle is flexor carpi ulnaris. So both of them coming off of the medial epicondyle, flexor carpi radialis goes to the most 2nd and 3rd metacarpals, more lateral. Flexor carpi ulnaris goes to the 5th metacarpal and the pisiform, that little bump. Same function, flexion of the elbow, flexion of the wrist, but now it does ulnar deviation. If you flex your wrist, kind of cock your wrist, you can see a series of tendons, all right? Flexor carpi radialis tendon is this first tendon right here. And palmaris longus tendon is the second. There's a little another one in the middle there. But it's the second one over here. Flexor carpi ulnaris is going to be over here. So I can see 3 tendons. One of them is actually going to my finger digits. About 15% of the population is missing palmaris longus in one or both forearms, and you'll only see 2 tendons, all right, instead of 3 structures right here at the wrist. So there's one there, one in the middle, and one there. About 15% of you will be missing one of the palmaris longus and one or both forearms. You'll see just the two tendons. All right, so that's the intermediate layer. Again, starting with pronator teres, and then moving to flexor carpi radialis, palmaris longus, and then flexor carpi ulnaris. So in lab, pay attention. Are you in the anterior compartment? If you are you on the thumb side or the little finger side? Okay, the flexor carpi ulnaris is going to run right along the ulnar bone. And on its posterior side, we're going to see the extensor carpi ulnaris. So the presence of the bone there is going to help you in locating that component. All right, now let's look at the intermediate layer. It forms a broad sheet, still coming off of the medial epicondyle, though some fibers will come off of the radius. Notice, however, its tendons. These tendons not only cross, the muscle not only crosses the elbow joint, so it does flexion, not only crosses the wrist joint, so it does flexion of the wrist, it also crosses the MP joints, so it's going to do this. So take the fingers and flex them in this direction. And it crosses the first IP joint. So it's going to flex the elbow, it's going to flex the wrist, it's going to flex the MP joints at the knuckles, and it's going to flex the first IP joint. It's going to do that. But it can't flex the tip of the fingers, okay? Because its insertion is the middle or intermediate phalanges. So it's going to stop right here, and those tendons actually split and attach to the sides of each phalanx. So it doesn't go to the thumb, it goes to tendons 2 through 5. There's another muscle that moves the thumb from the forearm that you guys don't have to learn. Again, median nerve is innervating all of these muscles so far, except for flexor carpi ulnaris, but we'll pick that up next unit. That's our intermediate muscle. Okay? So pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris is the superficial layer. And through the tendons of these muscles down here, we can actually see the muscle fibers of flexor digitorum and superficialis. Well, if there's a superficial flexor digitorum, there's a deep flexor digitorum. Okay. And this muscle does not come off of the medial epicondyle. That was the exception I told you about. Its tendons, so do not cross the elbow joint, but cross everything else all the way down to the distal phalanges. Which is why, in the previous slide, we saw the tendons of flexor digitorum and superficialis split. Because they stop at the middle phalanx, but flexor digitorum profundus goes all the way to the distal phalanx, and it's a deeper muscle, so it does this. Here are the tendons of flexor digitorum superficialis going to the middle phalanx, and then the tendon of flexor digitorum profundus passes through them to go all the way to the end, and thus it can move the tip of each finger. So, unique little piece of engineering to allow that. There is another muscle in the deep layer, all right, that you will see when you look at the models running along the radial bone, but you guys aren't learning that, all right? It moves the thumb. So the only muscle in the deep layer that you're learning is the one that moves digits 2 through 5. All right, so now, remember these have in common are flexing. So flexion of the elbow, flexion of the wrist, flexion of the fingers. Radial or ulnar deviation if they happen to attach to the wrist on one side or the other. So now let's move to the posterior compartment of the arm. Carter's lab manual has the brachioradialis in the anterior compartment of the forearm. I include it in the posterior compartment because it's innervated by the radial nerve. It starts posterior but then rotates around to the anterior radius. So because it's innervation, it's off of the lateral aspect and it's innervated by the radial nerve, so I throw it in the radial compartment. If you look at, I'll start to mention in the lab, we have pictures of bodybuilders up on the glass cabinet cases and taped to the cabinets and on the counters. And so there's a list in your lab manual of some of these superficial muscles that can be seen well developed on some of you, and even better so on bodybuilders. And certainly the deltoid is one that you can see even on a little tin, all right, as it forms a mastic. Brachioradialis, and I'm not a bodybuilder, I'm just showing you where it would be if you could see it on me. All right, brachioradialis does not come off of the lateral epicondyle, it comes off the shaft. So when you look at the lateral aspect of the forearm, it's going to be the uppermost lateral muscle here. And then we start seeing the others in rotation. So I usually pick a muscle, and then I identify other muscles as I go around the forearm. I always start with the same muscle, so I know I'm my starting point. Brachioradialis happens to be the one that I pick. You can pick pronator teres or extensor carpi ulnaris if you want to do that. But this one does not come off of the lateral epicondyle as the others will. Notice it doesn't cross it crosses the elbow joint, but not the wrist joint. Its major function is supination. So it's going to be synergistic. It's going to aid biceps brachii. That's our prime mover. That's our major function for supination. But brachioradialis, you can see here, is crossing around, and when it contracts, it's going to pull that radius over. All right? So it's also going to do supination. Now as we move slightly more medial, but we're still lateral, we have our group of muscles forming this mound. It's going to get enlarged as you extend your wrist. These muscles are coming off the lateral epicondyle in the posterior compartment. They're going to be doing extension. So it crosses the elbow joint, crosses the wrist joint. It's going to extend the elbow, assisting the triceps brachii, and extend the wrist. So we have extensor carpi radialis longus and brevis. For some reason, brevis is not in your lab manual. It takes both of those muscles to be the equivalent of flexor carpi radialis. Remember the insertion for flexor carpi radialis was second and third metacarpals? Extensor carpi radialis longus goes to second, extensor carpi radialis brevis goes to third. So when we're looking at these muscles on the models, they're right next to each other. Okay, so in sequence we're going to have brachioradialis, extensor carpi radialis longus, and then extensor carpi radialis brevis right next to it. We then have a group of muscles going to the thumb that you guys don't have to learn, but it's going to separate extensor digitorum from the carpi muscles. And so here we have coming again off the lateral epicondyle. It goes to the digits 2 through 5, all the way to the end of the fingers, and it's going to extend the fingers. So extension of the elbow, extension of the wrist, extension of the fingers. Radial nerve, again, does all this innervation. One of the fibers here is shown going to the little finger. On this diagram, it's not. So there is a muscle that sometimes considered to be part of extensor digitorum. Other individuals consider it to be its own separate muscle. So here they included it with extensor digitorum, here they did not. It's not listed as a separate muscle in your lab manual, and I'm not going to have you name it separately, but if you're wondering where, what moves the little finger, it's called extensor digiti minimi. And that's why it has almost its own separate development, so it's a lot easier to move the little finger by itself than to move the fourth finger, or all the other muscle fingers want to move along with it when you're doing this and you're trying to move that out. This one does it very easily by itself. Okay? We also have a muscle that goes to the forefinger all by itself. So those two can be a lot easier to manipulate. But we're not learning those. And then we end up with, you need to add this to your list because I left it off, extensor carpi ulnaris. Again, the flexor carpi ulnaris went to the fifth metacarpal in the pisiform. Extensor carpi ulnaris goes to the fifth metacarpal, but on the posterior side. Like that, flexor carpi ulnaris is going to do ulnar deviation, so it's synergistic for that function, but it's antagonistic because it does extension of the wrist, whereas flexor carpi ulnaris did flexion of the wrist. So it makes sense when you think of the compartment that we're looking at. Now, the nerve that innervates the extensor muscles of the forearm and the elbow is the radial nerve. Obviously, if I cut the radial nerve, which is coming off the brachial plexus and the axilla and moving into my posterior forearm, I'm going to still be able to extend my shoulder, right? Because I have deltoid doing that. And I have latissimus dorsi doing that. So I'm still going to be able to extend my humerus. But I will not be able to extend my elbow. And I won't be able to extend my wrist. Extension of my fingers will be weak because I have some other muscles in my hand that help to do that. All right, what if I cut the musculocutaneous nerve? Will I be able to flex and abduct my humerus at the shoulder? Yes, because I still have pectoralis major, okay? And I still have subscapularis for doing some medial rotation. If I cut my musculocutaneous nerve, will I still be able to flex my elbow? Yes, because I still have the median nerve doing those muscles off the medial epicondyle. Not very strong, okay? Because those are weak flexors. My major flexors will be paralyzed, my bicep, my brachialis, and assists to that. But I will still be able to flex my elbow with the anterior arm compartments. Will I be able to supinate? I've lost my biceps brachii if I lose the musculocutaneous. Will I still be able to supinate? Yes, because I have brachioradialis. Okay? And there's another muscle, supinator, that I'll show you in lab that supinates as well. It's found in the deep compartment of the arm that I don't have a list here. Okay, now, if I cut my median nerve, will I be able to flex my wrist? Weakly, because my ulnar nerve does 1.5 muscles. Okay? Now, if I cut my median nerve, which flexes the fingers and flexes the wrist, will I be able to extend my elbow, extend my wrist? Yes. All right. If I cut my radial nerve, will I be able to flex my fingers? Flexion of the fingers is done by median nerve. Radial nerve does extension of the wrists and fingers. If I cut my radial nerve, will I be able to flex my fingers?
Yes.
Yes. However, I can't do it tightly. So, radial nerve is cut. Can you extend your wrist? No. So flop your wrist forward. I can't straighten it out, so my flexor muscles are going to flex my wrist. Okay? Flop your wrist forward. Now try to squeeze your hand as tightly as you can. It hurts. Okay? You can't do that because you need to have your wrist slightly extended for the best physics and angle for those muscles to tighten up. So even though the radial nerve doesn't innervate any muscles that actually flex the fingers, you need that extension to be able to do it tightly. Okay? All right, so we'll add supinator to the extensor compartment on page 209. The extensor carpularis added and then supinator added. I'll show it to you in lab. It supinates and it's innervated by the radial nerve. Okay. Insertion is onto the radius. In origin is the humerus. Now, you'll notice a couple of muscles here that are shown in italics. Oh, here's supinator. So, after you put that down, I want to talk about those muscles that are shown in italics at the bottom. These are not muscles that you have to innervate, that you have to identify. The function is in its name. Abductor pollicis is going to abduct the thumb. Extensor pollicis is going to extend the thumb. They come off of the forearm, but I wanted to talk about the movement. So you don't need to know origin and insertion, but you do need to know what they do, abduct and extend the thumb. I need you to know pollicis means thumb. And then we're going to spend a few moments talking about movement of the thumb. We've avoided that so far. So, extension of the, flexion of the elbow, flexion of the shoulder, extension of the shoulder, flexion of the elbow, extension of the elbow, flexion of the wrist, extension of the wrist, flexion of the fingers, extension of the fingers, and then the midline of each hand is the third finger, so moving the other fingers away from that is abduction of the fingers and adduction. Movements that do those, muscles that do those, are in the hand itself. Right? And as I'll emphasize in our next unit, those muscles of the hand are done by the ulnar nerve. We're not learning any muscles of the hand in this unit. So abduction, adduction of the fingers are done by the ulnar nerve. Now, thumb is kind of weird. Thumb is rotated around so that we can oppose and grab things. And so while this is flexion of the fingers, and I'll go over it with you again in lab, and those of you in Lancaster's lab can ask him to do that. When this is flexion of the fingers, moving the thumb in that direction, so in the same plane, is abduction of the thumb. So when we flex and extend the finger, when we abduct, again, when we flex and extend the fingers, we're abducting and adducting the thumb. So flexion of the fingers. Now slide your thumb down your second digit in that same plane. That's abduction. Then when I extend the fingers and I bring my thumb back up in that same plane, that's adduction. Abduction of the fingers is this. When I move my thumb out in that same plane, that's extension. Adduction of the fingers, bringing them back to the third finger, is abduction, or adduction. Moving my thumb back is flexion. So let me do just the thumb. Extension of the thumb, increasing the angle in this plane, is not abduction but extension. So this is extension, this is flexion. Abduction, adduction. So whatever the finger pair of movements that the fingers are doing, choose the other pair for what the thumb is doing. All right? Abduction, adduction, extension, flexion. And that's because the thumb is rotated around 90 degrees, and so the same movements are in a different plane. All right, so let's get started on the lower limb. I found this image last night.
Oh. Nice view.
It hurts just to look at that. Okay. We'll see how far we get today in lecture. However, your lab quiz is going to be limited to the muscles of the hip joint above the thigh. The buttocks and the two muscles, the iliopsoas muscles and here. Okay? So I think that's enough for your quiz on Wednesday. Your quiz on Wednesday will include deep muscles of the back, like the erector spinae or gluteus capitis. Superficial muscles of the back, like trapezius and rhomboideus and levator scapulae. Muscles of the chest, such as and abdomen, such as the intercostal, diaphragm, internal, external obliques. Muscles of the scapula, such as trapezius and supraspinatus. And muscles of the upper extremities. That's more than enough for questions on it. Okay. So we'll probably get past the buttocks today, but I won't have anything, gluteus muscles would be on the quiz, but nothing else in the lower limb. So this is the region that would be homologous, if you will, to the posterior scapula. So we had muscles that did abduction in the posterior scapula and muscles that did external rotation. Same thing with our gluteal muscles, with the addition of the strong gluteus maximus, which does extension of the femur. So gluteus maximus is the most superficial muscle. Its origin is off of the posterior aspect of the iliac crest and the sacrum. And then it inserts along the gluteal tuberosity and down a band of connective tissue called the iliotibial tract, or also the tensor fascia latae. You may have heard of the IT, stretching out your IT tract. So that's also what we'll describe here is the tensor fascia latae. Its primary movement is to extend the femur. In other words, standing up, you're sitting in a chair, so pushing, extending, not just your knees, but extending your hip. So push yourself to a sitting position. When you're standing up, climbing stairs, you do that to push yourself up to the next level. All right? So that's its main function. Secondary is lateral rotation of the femur. Lateral rotation of the femur is going to bring, because of the change in the knee joint, lateral rotation of the femur is going to bring my foot more medial. So if I laterally rotate my femur, I'm doing this. Notice my foot becomes more medial. If I medially rotate my femur, my foot becomes more lateral. Okay? So that's lateral rotation, medial rotation. Think about what the femur is doing. Once we remove the gluteus maximus, we have gluteus medius and minimus, which I have here on the same screen because they have the same function. The medius is going to cover the minimus, but both of them will insert on the greater trochanter, which is a lateral and posterior process. So gluteus medius is going to come off the iliac crest, gluteus minimus just inferior to that. And then both of them will insert onto the greater trochanter. Major function is abduction. So these are the equivalent of our supraspinatus and deltoid muscle. So abduction of the femur is doing this. All right, we have a whole group of muscles that do the opposite abduction. Abduction of the femur, abduction of the humerus. Again, we're not going to worry about innervation. Now we're going to, so that's equivalent of deltoid and supraspinatus. Now let's look at the muscles that are equivalent to infraspinatus and teres minor. And these muscles have their fibers traveling horizontally. So because of that, they're going to do lateral rotation. This is the movement you would do if you're going to cross your ankle over your knee or sit cross-legged. We'd be doing lateral rotation. So piriformis, there are several that are seen here. Piriformis is this one. It's a broad pyramid, triangular shaped muscle. It is the major lateral rotator. So it's kind of like the infraspinatus. And all of them are going to go to the greater trochanter. The piriformis can be found in lab because in almost everybody and in all of our models, the greater sciatic nerve is going to come out just inferior to the piriformis. So the muscle that's right superior to the piriformis is going to be the sciatic nerve. That will help you find that. We skip one, so unfortunately we never talk about the twins here. We skip one, and the next muscle, the only other muscle we'll learn in the buttocks, is the obturator internus. Called the obturator because its origin is off the fascia of the obturator foramen. Internus because it comes from the inside of the pelvis. The tendon, the muscle passes through the lesser sciatic notch and then out onto the greater trochanter. In our models, you'll only be able to see this slender slip right here on our lower limb model. We do have separate hip models, which are helpful because then you can actually see the broader origin of the obturator internus. Now I want to go to, let's see. So here's a view from the models. So here would be gluteus medius. Gluteus maximus has been cut. Here is piriformis with the sciatic nerve coming out just inferior to it. Skip one, and then this muscle right here is obturator internus, and you can see it coming off of the obturator foramen right here. This is the large muscle model lab, not the little ones that are on the tables. Okay, I want to go to this group here that are above. So, skip to the iliopsoas. what muscle is located right here? The iliac crest, the lumbar vertebra, and lower ribs. Quadratus lumborum. Okay. So quadratus lumborum is going to be right here, kind of posterior to this muscle. Both of them are forming a support for the kidney. And this muscle has its origin off of the lumbar vertebra as well, the bodies of the lumbar vertebra. And it passes down. It's going to function to help flex the vertebral column. But its major function is it passes across the hip joint and inserts onto the lesser trochanter. So its major function is flexion of the hip. It joins with this muscle here called the iliacus. So above the hip we have psoas major and iliacus. Where they join, it's hard to differentiate those two. So where they insert on the lesser trochanter, it's hard to differentiate which is which, except by position. And so at this point, they're called iliopsoas. But they really start out as two separate muscles rather than two heads. Okay? And they're going to take the femur, as you can see here, and rotate it around like that. They're going to reach inside and grab the femur, so that's lateral rotation. You've probably heard that when you do sit-ups, when you're trying to exercise your anterior abdominal muscles and get a flat tummy and get that 6-pack or 8-pack or 12-pack, that you need to flex your knees when you do sit-ups instead of keeping your knees extended. These muscles are the reason why. They are so strong that they're typically stronger than your abdominal muscles. If you lie flat on your back and try to sit up, these muscles, especially psoas major here, is strong enough to pull you into a sitting position. Hence, you don't even use your abdominal muscles. However, their function is to flex the femur. So if you go ahead and flex the femur, that shortens those muscles. So even if they contract, they can't create any tension because your femur is already flexed. And now if you're going to sit up, you have to use your abdominal muscles. Okay? So flexing the knee before you do sit-ups is to take those muscle contractions out of the picture. All right, so before we look at muscles of the lower extremity, let's talk about innervation. Okay? In our upper extremity, we had 2 compartments for the arm and 2 compartments for the forearm. Innervation of anterior arm was musculocutaneous. Innervation of anterior forearm, median. Innervation of posterior arm and forearm was all radium. Okay? When we look at the lower extremity, we have 3 compartments in the 2 components of the lower extremity. We have thigh and leg, and each of those has 3 compartments. So we have anterior thigh, posterior thigh, and medial thigh. What would be the major function of anterior thigh? It has 2, depending on which joints the muscles cross. The muscle joints cross this, the muscles cross this joint, flexion of the thigh, or flexion of the femur. If the anterior muscles cross the knee joint, extension of the knee. Okay? If you look at the posterior compartment and the muscles cross this joint, we have extension of the thigh. If the muscles cross the knee joint, we have flexion of the knee. All right? So the 3 muscles of the posterior compartment, the hamstrings, that's what they do. They extend the thigh and flex the knee. Medial compartment, major function?
Adduction.
Abduction. Okay? One muscle of the medial compartment will flex the knee. But all the muscles will do abduction. So those are the 3 compartments of the thigh. Innervation is femoral nerve to the anterior thigh, obturator nerve to the medial thigh, and tibial nerve to the posterior thigh. Like the radial nerve, the tibial nerve goes into posterior leg. So tibial nerve is going to do posterior thigh and posterior leg. All right? And we'll come back to innervation of the leg in just a bit. So now let's go back to, I think the next in your lecture notes is the posterior thigh, biceps femoris, or the anterior thigh? Which one?
Posterior thigh.
Posterior? Okay. So posterior thigh muscles, you can see here in the model. once we remove gastrocnemius, there are three muscles in the posterior thigh. They have a common origin, which is the bony process that you sit on. Anybody remember what that is? Ischial tuberosity. All right, so all three muscles of the hamstring are going to insert onto the ischial tuberosity. They are called the hamstrings because if you feel behind your knee, you can feel a thick tendon cord on the lateral aspect and another one on the medial aspect. So an iron hook passing through those is helpful in hanging up the knee. The three muscles form those two tendons, all right? So one muscle goes laterally, two muscles go medially. The one muscle that goes laterally has two heads, so in essence we're balanced. So here's some clues on how to remember which is which. The lateral muscle, again, origin is the tibial tuberosity. It's going to pass lateral, and our lateral bone is the fibula. F in fibula, F in femoris. So that can help you remember that biceps femoris is the fibular side muscle of our group. There's also a short head to the biceps femoris that comes off of the femur, doesn't cross the joint, and that's why we have the word bicep, two heads. So the long head and the short head, both of them are going to insert onto the fibula. All three muscles have the same function, all right? So all three muscles are going to function to extend the thigh and flex the knee. You just put ditto marks down for those. Biceps femoris goes lateral to the fibula. Now here I have lateral rotation of the knee. That's just a tiny little bit. When you stand erect at attention and you hyperextend your knees, that locks them. And to unlock them, you have to do a slight rotation, just a little bit of the femur on the tibia or the tibia underneath the femur to unlock them. We're not talking about rotation of the entire muscle rotating as we do with the femur and the humerus. It's just locking and unlocking the knee. And I put that in there just for accuracy. I don't ask questions about that. If you're looking at knee injuries, you'll be working with that. So the next two muscles are semi-muscles, semimembranosus and semitendinosus. So how do we remember that these are medial? Medial starts with M. So semimembranosus goes from the ischial tuberosity to the tibia, medially. Semitendinosus, tendinosus starts with T, and the tibia is our medial muscle, all right? So semimembranosus and semitendinosus are medial. Same function though, they are going to extend the femur and flex the knee joint. And again, I've got the knee rotation up there, but I don't ask questions about that. So these three muscles are the ones that form the posterior thigh. So here you can see that we have the ischial tuberosity here. And then we have this is going to be lateral. This is our greater trochanter. And so we have the biceps femoris, long head going to the fibula, and the short head is going to be right here. On this side we have two muscles, semimembranosus and semitendinosus. Semitendinosus is superficial. It's a little hard to see up here, but it forms a narrower tendon that lies superficial to the broader, deeper, wider, more membrane-like muscle, which is semimembranosus. Okay? So semitendinosus is superficial. The wider one here is going to be semimembranosus. But they both have the same attachment on the tibia. All right, looking at the anterior compartment of the thigh. This is probably the busiest of the muscles because we can see a whole bunch of different compartments. But we have, here's our iliac crest and our pubic bone. Here's psoas major and iliac is coming underneath the inguinal ligament along with the femoral artery and nerve, and we can see just a little bit of the iliopsoas right here. These are all muscles in our adductor compartment. So this is our anterior compartment of the thigh. We'll come back to tensor fasciae lata in just a bit, because that's part of another grouping. And we have two major origins. Remember the ASIS, anterior superior iliac spine? We have two muscles that have their origin from that, our tensor fasciae latae and our sartorius. The rest of the muscles of the anterior thigh are the grouping of four that form the quads. Remember the quadriceps femoris tendon? So we'll start with that. The rectus femoris, the other three are called vastus something or other. Right? Rectus meaning straight. All four muscles are going to have a common point of insertion, the tibialis tuberosity. All right, right here, this is not attaching to the knee, but it's going to come all the way down here to the tibial tuberosity. It's been just shortened there. And so it crosses the hip joint, not from anterior superior, but from anterior inferior. It's the only one of the quad muscles that crosses the hip joint. So it's going to flex the femur, but extend the knee. The other three muscles are found on either side and deep, the rectus femoris. And they are known as the vastus muscles. So their origin is off of the shaft of the femur. None of them cross the hip joint, so they only extend the knee. Vastus medialis is on the medial side. Vastus lateralis is lateral. In forming a bed or a floor, you have to take the rectus femoris off. You have vastus intermedius. When you look at the bodybuilders, rectus femoris gets swallowed up by the increase in size of the vastus, which means large muscles. Both vastus medialis and vastus lateralis get huge. And the rectus femoris is almost completely, not completely, but it becomes much smaller in appearance. So all three will join rectus femoris to insert on the tibialis, the tibial tuberosity. So those four muscles are known as the quadriceps femoris. One crosses the hip joint, so that flexes. All four of them will extend the knee. And the nerve of our anterior compartment is the femoral nerve or the femoral nerve. The one different muscle will, these other two here that we see, the sartorius. Sartorius refers to clothing, tailor, and this muscle helps you sit cross-legged. So the movement you would do with your lower extremity to sit cross-legged is what the sartorius does. It crosses the hip joint at anterior superior iliac spine, so it flexes the knee. Because it crosses lateral to medial, it rotates the thigh. Because it crosses medial to the tibia, it flexes the knee. So it does that. As if you were going to sit cross-legged, like the tailors would do before they had sewing machines. ASIS, crossing medially to the tibia, flexes the hip because it crosses the hip joint, flexes the knee, because it crosses the knee joint medially, and then laterally rotates. And you can see that muscle right here. The other muscle that crosses, that has its origin off of the anterior superior inferior spine is the tensor fasciae latae. So I thought I have it on